The link between obesity and cancer is widely acknowledged in the scientific literature, yet what is far less discussed and more insidious is how deeply this connection is shaped by the social determinants of health. Obesity does not occur in a vacuum, and neither does cancer. Instead, these conditions are entwined with systemic inequities that affect where people live, what they eat, how they work, and what kind of healthcare they receive. Socioeconomic status, racial and ethnic disparities, neighborhood environments, and access to medical care collectively determine not just who becomes obese, but who goes on to develop cancer and who survives it. These factors don't just add weight to the burden of disease. They tilt the scale entirely, making obesity-related cancers a profound issue of social justice. Poverty, for example, is a powerful predictor of both obesity and poor cancer outcomes. Individuals with lower income often live in neighborhoods where healthy food is scarce, gyms are unaffordable, sidewalks are unsafe, and healthcare access is fragmented or absent. This is not a matter of individual choice, but of structural design. In these settings, cheap, energy-dense foods become dietary staples, while processed products replace fresh produce due to cost and availability. Over time, this nutritional environment increases the risk of obesity, particularly visceral fat accumulation, which is strongly linked to multiple cancers including colorectal, breast, liver, kidney, and endometrial cancers. But the problem extends beyond exposure to risk factors. Once obesity is established, lower-income individuals often lack access to preventive services that could mitigate cancer risk, such as regular screenings, early diagnostic imaging, or even basic metabolic health assessments. Obesity complicates diagnosis by masking symptoms and delaying detection, but when combined with limited healthcare access, the result is often diagnosis at later stages of disease. These advanced cancers are more difficult and costly to treat, and outcomes are generally poorer, contributing to the widening mortality gap between rich and poor. Racial and ethnic disparities further deepen this divide. Non-Hispanic Black and Hispanic communities in the United States, for example, experience disproportionately high rates of obesity and obesity-related cancers. But these statistics reflect more than genetics or personal behavior. They are the legacy of redlining, economic disinvestment, environmental injustice, and decades of unequal treatment in healthcare settings. Black women, for instance, are more likely to develop aggressive forms of breast cancer linked to obesity and more likely to die from it, despite comparable or lower incidence rates than white women. These disparities are not coincidental, they are systemic. Even when treatment is available, it is not always equitably delivered. Studies show that patients from marginalized communities are less likely to receive guideline-concordant cancer care. Obesity can further compound this bias, as larger-bodied patients often face weight stigma and discrimination within healthcare settings. Physicians may assume symptoms are weight-related and delay appropriate imaging or referrals. Medical equipment may not be designed to accommodate larger patients. And implicit bias can result in less aggressive treatment plans, lower access to clinical trials, and poorer communication between providers and patients. All of these factors contribute to higher cancer mortality among obese individuals from disadvantaged backgrounds. Insurance status plays a role as well. Those without private insurance may delay seeking care due to cost, avoid follow-up visits, or forego medications and cancer therapies entirely. Even in publicly funded systems, lower reimbursement rates and higher patient volumes often translate to rushed care and limited preventive services. This creates a two-tiered system in which early detection, the single most effective weapon against cancer, is far less accessible to those at highest risk. Moreover, environmental stressors tied to poverty and discrimination may biologically intensify cancer risk in obese individuals. Chronic stress elevates cortisol, disrupts sleep, alters immune function, and worsens insulin resistance, all of which can accelerate tumorigenesis. In this way, the very conditions of inequality not only shape behaviors, but also directly modulate the body's internal landscape, creating a physiological feedback loop that reinforces disease. Yet despite the gravity of this issue, public health responses often remain narrowly focused on individual responsibility. Campaigns to reduce obesity emphasize willpower, portion control, and exercise, without addressing the socioeconomic traps that make healthy choices inaccessible for millions. Cancer prevention efforts rarely focus on obesity in poor or marginalized populations, and even fewer address the complex intersection of obesity, race, poverty, and healthcare injustice. This gap in strategy allows disparities to deepen while giving the illusion of progress. To break the obesity-cancer cycle, we must go far beyond calorie counts and screening guidelines. Policies must address food insecurity, eliminate food deserts, invest in walkable neighborhoods, and provide equitable access to preventive and specialty care. Obesity treatment must be destigmatized and made affordable for all populations, not just those who can pay out of pocket or access elite clinics. Cancer care systems must be restructured to ensure early detection and full treatment regardless of income or weight. And most critically, social determinants of health must be acknowledged not as background noise, but as primary drivers of risk. The reality is stark. Obesity-related cancers are rising fastest in the populations least able to fight them. Without addressing the underlying inequities, we risk widening the very gap that the healthcare system claims to close. Obesity and cancer are not just biological diseases, they are symptoms of structural failure. If we fail to confront that truth, we will continue to lose lives not just to tumors, but to inequality itself.